All right, looks like we got some folks trickling in here. We'll just give it another minute or so for anyone else that's logging in. If not, they can keep coming as we go. A lot of folks are already doing it, but as the message Eric has in the chat, make sure you put your full name, license number, and if you have a non-Maine license, make sure you specify the state your license is in. Make sure we get you all credit for being here today. And if you have multiple folks on the same computer, make sure you put everyone's names and licenses there so everyone gets captured. Great. Well, as folks trickle in, we'll go ahead, we'll get started. Take this chance and say, I think most folks know me at this point, but I'm Joe Minicello, currently the EMS fellow here in Portland, sticking around here in a couple months when fellowship's over. I have the pleasure of introducing two of our emergency medicine residents here. Andrew Jones, who's one of our second years, Brendan Connolly, one of our third years, who will be talking about all things seizure today. As always, as we go through, if questions come up, feel free to put them in the chat feature or the Q&A. One seems to work better for some folks. We will monitor that as we go. We'll also have time for questions at the end. So without further ado, I'll pass it on to Doctors Jones and Connolly. Thanks, folks.
Thanks, Joe. And thanks everyone for being here. I'm Andrew. I'm one of the second-year residents.
Brendan, a third-year resident.
Joe invited us out to talk about seizure disorders, mostly focusing on like the EMS and pre-hospital setting, but we get to share a lot of our perspective as ED providers and that interface when you all bring us these folks from the scene or from the street. Let's see if we can get this working. As far as financial disclosures, we're residents. We don't have any money, so we have no financial disclosures to make. Objectives, these are just a few of the things we want to get through today. We have to understand kind of the epidemiology, the underlying pathophys of seizures, define and recognize various types of seizure-like activity, and then relevant details. The Maine EMS protocol will review that. Discuss kind of pharmacologic strategies and management, also supportive care for seizure, and then we want to apply these kind of in a case-based format. So I'll kind of take the first half, and we'll take over the second half, and then we'll have question and answers at the end. Feel free to chime in, as Joe said. So just as an introduction, like what is a seizure? Seizures are disordered electrical activity within the brain, which can manifest in a wide variety of physical symptoms. So this really gets down to the nitty-gritty, the actual neuron level within the brain, where these neurons are firing and how frequently and how widespread manifests what we actually see as the seizure-like activity. There's a balance between glutaminergic and GABAergic neuronal activity and neurotransmitters, which gets to the pathophys and the ecology of how we manage these things. But I think that basis is just helpful for understanding what you're actually seeing manifest in the physical symptoms. It's all about these neurons firing within the brain and then down on through the peripheral nerves. So as far as like epidemiology and the pre-hospital seizure burden, in the US, the incidence of lifetime seizure is as high as 11%, which was kind of shocking to me. One essentially have had some form of seizure in their life or will. 4% of these are represented by pediatric febrile seizures, which we see not infrequently related often to like viral illness. Seizure and epilepsy related complications account for up to 5% of 911 calls in a few studies I looked at. Calls is something for like a seizure. And then overall, it's a 1.6 million ED annual visits for seizure evaluation in the US. And about almost 500,000 of those come out to be new onset seizure disorders. So it's a fairly large grouping. And as you all know, oftentimes people are calling for somebody who's unresponsive or who passed out or whatever, and it's called like, hey, so this person had a seizure, and which can be difficult to tease out, but we'll get into that. So as far as like morbidity, mortality, why do we care about seizures? Why do we care about treating and intervening on those? Well, aside from causing like a very observers, if you've all seen somebody having a seizure, it's very visceral, right? And we all just want to like do something. And it, for the layperson especially, it like triggers a lot of emotion. The reason it matters is because permanent neuron injury can occur and resistance can arise after like that 5-minute mark. And as early as like 5 into 30 minutes. And in a couple studies, and one in particular, the mortality rate for first seizure episode leading to epilepticus approaches 20%, which 1 in 5 is a pretty stark number for like that you could die from your seizure. A lot of that has to do with like airway compromise and that sort of thing. And then as far as the importance of intervening early, why this matters is because continued seizure activity causes modulation of those neurotransmitters that I mentioned, those receptors that can become more resistant to medications, which leads to decreased effectiveness in both immediate and in the long epileptic drugs that we use, i.e. leading to refractory seizure. So as far as seizure recognition, this is a framework that I kind of have built in my brain. Is number one, is this a provoked or an unprovoked seizure? So most of the common things we often see for provoked seizures is like medication non-adherence, whether somebody, you know, is on the street and they have their medication stolen, or they lost access to their insurance, or they just stopped taking their meds and then they have breakthrough seizures. Hypoglycemia, toxidromes, alcohol withdrawal. This is one we see very frequently in the department, where we get called to the B side because somebody has not had a drink in a long time since being in the yard, and they have a breakthrough seizure from that, or withdrawal seizure rather. Also, other like primary disease processes can lead to seizures. So think like intracranial bleeds, strokes, traumatic brain injuries, severe electrolyte derangements can also cause this. If you look this up in a textbook, the list goes kind of on and on and on for what can be underlying. And that's really our role with the patients in the emergency department. And what a lot of the testing that we do is try to sort out, like, is there an underlying cause, or what was the underlying cause for why this person has a seizure? That's unrevealing. Like oftentimes these are deemed to be unprovoked seizures, which argues more for like an actual epilepsy and epileptiform seizure activity. So that's kind of one approach. And the others generally have somebody who's seizing as a generalized, or this is a focal seizure. And that's characterized both on the classic movements and then their EEG findings. Status epilepticus and why that matters. The definition of status is any seizure lasting more than 5 minutes, or importantly, 2 seizures without a return to baseline. So we sometimes see that where somebody has a seizure, but then they're still kind of post-ictal, they never really clear, and then they have a subsequent, considered essentially one seizure episode. Let's see if I can move this over here.
Arrows there.
Those arrows there. Okay, so we'll see if this video works or not. This is a video of a generalized tonic-clonic seizure. Oh, maybe not. Well, I don't know if the video is it playing on your end, Joe?
I don't see it playing, unfortunately.
Oh, that's all right. Well, if you could see this video, it's a really great like depiction. This is obviously somebody who's like an inpatient and is being monitored for seizure activity. But what it starts out is this person is sleeping, and then you see them start to tense in all 4 extremities. They have this tonic phase, and then it progresses to a generalized clonic phase where they're shaking with all 4 extremities, and it shakes the whole bed. And that is a generalized tonic-clonic seizure, formerly referred to as like a grand mal seizure. Whereas this little neonate has more what we would call focal clonic seizures. And so in this one, that right arm, this child like has an episode where this right arm has this tonic activity, this kind of shaking, and it's isolated just to the right upper extremity. And if you could actually see this on an EEG, which is what epileptologists and neurologists do, not something we do in the emergency department, at least here at this institution, is if you hook them up to an EEG where you can actually monitor the electrical activities and brainwaves with the seizure activity, this is what you see with it. Why you're seeing it all over the brain and manifest throughout like their peripheral nerves as well. Whereas like a focal seizure is one particular area or it's within the brain that is firing and going haywire. It's important to kind of bring up seizure mimics and also misses for seizures in my mind, especially for you all, because you're just getting called out for like somebody's having a seizure. But is it a seizure? Or is it something adjacent? One of the things that's really important, and I actually had experience with this just recently, I was like walking by somebody who has just been discharged in the department, and they became like unresponsive and had kind of this twitching movement. And then his blood pressure bottomed out, and he cleared and came to, but what it actually was he was having an episode of ventricular tachycardia and was near syncopal from that episode. He wasn't actually like seizing, but for the layperson, they may not know that. So cardiac arrhythmias, I think, are really important and perhaps under-recognized for why somebody might have seizure lighting. And as a personal thing for me, like when I'm like documenting the history in the chart and things like that, I usually am referring to this as seizure-like activity, because without an EEG proven seizure, we don't know for certain if that's what it was. Unless, of course, somebody has like a well-described seizure disorder and then they had a very classic or characteristic seizure episode for that. That's totally safe to call this was their seizure. Other episodes like syncope and vasovagal syncope or static syncope, when somebody passes out, they can often have these kind of twitching type movements associated with it, but it's not true seizure activity. One that we see not infrequently, and we sometimes have folks who come as repeat visits to the emergency department, is for psychogenic non-epileptic seizures, which you may have been referred to as pseudo seizures. The term pseudo seizure has fallen out of favor in like not really understanding the underlying disease process so much. But these are not epileptiform, meaning it's not those actual firing of neurons within the brain, but it is manifest in kind of this atypical and odd pattern. One of the classic characteristics is that they immediately will return to baseline, not have a post-ictal phase. And then there's other things like movement disorders, things like Parkinson's and kind of the pill roll tremor that people can have. That's not so much a seizure, but can mimic it. And then one of the other things that's sort of scary to me is this idea of non-convulsive status epilepticus. This is on the differential diagnosis for somebody with prolonged altered mental status that is not clearing. And it's I saw one case of this in the ICU with somebody that actually it was from cefepime toxicity, so it was provoked seizure activity from cefepime that they had been getting at large doses for some time. But they had subclinical status and had been in a few days that we all thought was just encephalopathy from the infection that was being treated, but in reality was actually this person had been seizing for probably days. So they ended up getting loaded with benzos and actually cleared and woke up like fairly shortly thereafter once the seizure was broken. The only caveat and like little pearl I would add to this is for psychogenic non-epileptic seizures, or PNES, up to 10% of these patients also have concurrent epileptiform activity, meaning they have like a real true epilepsy type seizure disorder and psychogenic seizure. So sometimes it can be really hard to tease out. Moving forward into kind of like more applicable to the Maine EMS protocol. So we'll be referencing gold slides or pages 8 and 9. Just as a segue, there's a couple of important highlights that I wanted to bring up, and then I'll turn the time over to Brendan. But number one is like the ABCs always come first, right? Airway, breathing, circulation. One of the important things that we sometimes see in the movies, you know, how like they're always like, oh, turn them on their side and like shove a wallet or stick in their mouth. Like that's not at all recommended. Most of the time for seizures, and suctioning and just providing support that way. Sometimes they need some supplemental oxygen. It's never wrong to provide that for somebody who may have borderline, or you can't get a reliable pleth or pulse ox if they're shaking or moving, or you're just arriving on the scene. But very rarely these people ultimately end up need to be intubated and so forth. They often just need to kind of support through it. And for uncomplicated seizure under 5 minutes, medication administration is often not indicated or necessary if they're like, you know, if they're safe, they're not suffering any trauma, they're not aspirating, their airway is not compromised, they're not desaturating. Like oftentimes these folks will break their own seizure within just a couple minutes. And then we'll get more into details of this, but the intramuscular route has been demonstrated to be non-inferior to IV. So obtaining access should not delay treatment for seizures. And then for us and our perspective, and something I just wanted to pass on to all of you as our colleagues, that can be very helpful to get some collateral information from those on the scene when it's appropriate. Getting information about the seizure timing, what it actually looked like. Was there any trauma when they had the seizure? Do they have a seizure disorder? What medications are they on, and have they been taking them? And then possible exposures. We, of course, will take all that same history and try to tease that out ourselves. But sometimes these folks come to us and they are post-ictal or altered, and we can't really get that information. And sometimes that's really helpful from you all when, you know, we're taking handoff a report from you to hear from like somebody that was there on the scene, what actually occurred, transpired, and precipitated the seizure. So this is kind of, I think, our transition point here to talking more about the protocol and getting into more of the pharmacology.
Yeah, sounds good. All right. Yeah, thanks everyone again for having me. This is my my turn, Andrew. Got everything warmed up for me. So this is the gold 8-9 piece of the protocol from the Maine EMS protocols. Obviously a great reference that can walk you through things that consider, and then some of the kind of like caveats to seizure management and other things you need to consider. So we're going to go through this in pretty good detail in the next few slides, but just wanted to sort of post some of it up to start. And obviously that's something you can always reference both on the job. I think, you can pull this up and it should be a pretty quick reference, then good things to review as well. These are great for me to review. I obviously don't look at the Maine EMS protocols as often as some of you probably do, and as Joe and Eric and others do, but it's great for me to have too, and just kind of know what is offered in the field before they get to us. And then this is a lot of the management we do in the emergency room pretty much follows these steps as well if someone's having a seizure in front of our eyes. So happy to see everything here. Pharmacology, so these are just different, but most seizures are self-limited. If you see someone who has a seizure and the seizure breaks, you do not necessarily need to give medications, but it's good to kind of run through your mind, like if someone's seizing in front of you and you need to give some medications, then you can start with IM administration. So if you do not have an IV access established, then IM is just as efficacious as IV and has some advantages in terms of time to administration, obviously. Midazolam, obviously, for most seizures is going to abort most seizures on its own and will not need a second or third line agent to do so. Always, always, always consider in female patients if they are pregnant or if they have recently been pregnant. You can have eclampsia, which we didn't talk about too much what exactly that is. It's a seizure disorder within pregnancy that's related to high blood pressure in pregnancy. You can have that up to 6 weeks is the typical literature after giving birth. And so it's not just a disorder of pregnancy, but also the postpartum realm as well, up to 6 weeks. So always consider that. Always try to tease out the history of a woman has recently been pregnant, along with if they are currently pregnant. It is helpful if you guys are giving multiple doses of midazolam, call the med control and let them. It's very helpful for us in the emergency department to say this is not just someone who sees and is post-ictal, but this is someone who's going to need really active management because they've gotten 2 doses of midazolam. They're going to need to be in critical care. We're going to have to start thinking through our second line medications. And then there's other, we'll talk about some of these, but think about trauma, think about their electrolytes. We just said pregnancy, and then always got to watch ABCs like Andrew talks about, airway management too. So. Benzos are the class of medication that is the first line for a seizure, for aborting seizures. They act on GABA A receptors in the central nervous system. It's a broad class, just to name a few that you might have heard of, but alprazolam, chlordiazepoxide, clonazepam, diazepam, lorazepam, midazolam, oxazepam. That's maybe like a third of the benzos that are out there. All sorts of routes. So obviously IV, IM, you can give these orally. Intranasal is one route. And then there's some like rectal medications as well for rescue that a lot of parents are. They're generally well tolerated. One thing you want to watch out for, of course, is respiratory depression. People, of course, palsy and confused. You can get headaches. You can pass out, and then nausea, vomiting, and tremors. In babies, they can cause bronchospasm, so it's just another reason to watch for airway issues, and then can sometimes cause diplopia and vision changes. Like I said, they are first line in seizure and alcohol withdrawal syndrome, and then they're also indicated for all sorts of other things like anxiety and catatonia and some other things as well. So a lot of this is from the Maine EMS protocols, but midazolam is the one that is part of the protocol. One thing that I didn't put on here, but for people who are having active seizures or who are in status epilepticus, one of the biggest pitfalls, there's really 2 big pitfalls. One is not giving medications fast enough. So when people are, standing around debating, should we medicate, should we not medicate? The answer is probably that you should medicate. And then the other is underdosing. And so people, a lot of times with people in the emergency room, they'll say like, all right, let's give 1 of lorazepam IV if they have an IV, or let's give 2, and really the max dose is 4. And like a lot of people, if they're in status, should be getting 4. I'm never going to fault anyone who is trying to be safe about giving sedating medications. Obviously, that's always a concern as well. We don't want to over-sedate people and cause other airway issues, but those are 2 big pitfalls that I didn't put on the slides. One is just not giving medications early enough. The other, underdosing the initial doses of benzos. IM should be preferred for midazolam. The adult max dose is 10 milligrams, and that is what you can start with. For really anyone over 40 kilograms should be getting 10 milligrams. You can repeat this dose every 5 minutes of midazolam. That's both for IV and IM. And you want to do a max of 2 doses for adults and pediatrics. Again, you see the max here is 10 milligrams. And you want to go with like a weight-based dose of 0.2 mg per kg for pediatrics. Everything's cut in half for IV. So if you have an IV and someone seizes, then definitely go IV. Adults can get 5 milligrams IV. Pediatrics, you see it's just cut in half, 0.1 with a max dose of 5 again. You can repeat this 3 times. 2 times for a total of 3 doses. So for IV, we have a little more leniency to give an extra dose, whereas IM, you want to stick to 2 doses. This is what we were referring to earlier, that there have been some large trials showing that IM administration is really less efficacious as IV in a lot of ways, and can help abort seizures earlier and kind of get you seizure free much earlier. This was a large study in 2012 that scattered a lot of this literature. As you can see, there are 4,000 people were involved, 79 different hospitals, 33 agencies, got several hundred patients, and kind of studied IV or IO lorazepam versus IM midazolam. The primary outcome was rescue or cessation of seizure without the need for rescue therapy. They found that at the time of hospital arrival, the IM midazolam group had 73.4% of patients, 70% of patients were seizure free, and the lorazepam group was 63%. And so there's a pretty significant difference in the number of patients showing up to the hospital seizure free. The time to administration was much shorter with midazolam IM. Just once you said, I need a med, it was only 1 minute before midazolam was given, whereas it would be 5 minutes before lorazepam was given, since there's oftentimes need to start an IV. And then, so just like showing that lorazepam is a little bit more efficacious when you are able to give it. So if you had an IV and could get it in, the seizure usually stopped in about half the time. It was 1.5 minutes versus about 3 minutes. That said, the overall time from when you said, I need a medication to when seizures stop is about the same and slightly favors midazolam. And that all really has to do with the fact that you can give it IM, and it's just as efficacious, and overall has a little better data showing that seizures are stopped by the time people get there. So this is just to show, this is where a lot of the Maine EMS protocols come from, and it's why we can really rely on IM rather than having to do IV. Or wait to get an IV. This is just to show these are some things we're thinking about in the emergency room. So this is the second line. This is, again, after benzos have been maximized. So if you guys had only given 1 dose of benzos in the field, we should really be giving another dose of benzos before we move to these other medications. This is from the Maine Medical Center emergency guidelines. So these are pretty good to look up. You can just Google MMC guidelines, and then it'll take you to this page. So again, we are trying to maximize benzotherapy as well, just like you guys are doing in the field before we move to some of these second line agents. This essentially recapitulates what was on this, but we're doing Keppra, Depakote, or Phospheni. And it's like a nice little symmetric, like 60, 40, 20 for the weight-based dosing with max of 4,500, 33,000, or 1,500. Reaching for Keppra. For people who are like not in status still and maybe don't have aren't having an active seizure, we will often ask for like a 20 mg per kg load. And that's also for like trauma patients who have a, suspected head injury. We'll ask for a 20 mg per kg load as well to sort of avoid seizures from happening. This is some things we consider metabolic and liver disease. We want to avoid Depakote, and then sort of like concerning, ACLS type picture if they're in shock or have an arrhythmia, we're going to avoid phosphenia as well. So, but there's there's a large trial in 2020 that's established there's effectively no difference between these three for breaking seizures and having breaking seizures and becoming conscious again. So any of these three are fair game for us once they get to the hospital and we need a second line agent. This is third line. So if they, we've given them a second line, they're still seizing, we're gonna get them on, propofol most likely, sometimes midazolam concurrently to have as much benzos as we can along with propofol, both of which act on the GABA receptors in the central nervous system and can help break a seizure. Obviously keep people titrated and manage their airway if they're intubated this way too. So this is also part of the MMC guideline. Is there things we're thinking about? There's fourth and fifth line things as well that are not done in the emergency room and are just done with critical care management. So that's, this MMC guideline goes even further. But I'm going to stop it here just so we can show like our endpoint in the emergency room is we got to intubate and get them on a drip to have some constant medications going in. But just to sort of go back, this is the bread and butter. This is, midazolam for people in status or having active seizures. And that's all in the Maine EMS guidelines. I think a really important thing is eclampsia. So this falls right into the EMS guidelines as well. And so it is extremely critical intervention that you guys can give in the field to ensure that people who are pregnant or recently pregnant can be safe when they're having a seizure. Magnesium is the first line. And so you want to, if you have an IV, you're going to give 4 grams over 15 minutes. If you don't have an IV, again, go right to IM. You can give 8 grams total when it's IM, and you want to do 4 grams into each butt cheek. If the seizure continues, you give 2 grams over 5 minutes. You're always working to establish an IV for magnesium, but you can give it IM, 2 grams over 5 minutes. Even if the seizure stops, you're not done giving magnesium, so you want to start 1 gram per hour. Another thing to note, this should be dosed obviously for you in the medications you're pulling, but it is dosed in grams. It's not milligrams. So obviously, if you were to somehow give 2 milligrams of magnesium or 4 milligrams, you would be vastly undertreating their seizure. So just to keep in mind, this is dosed much differently. You can give benzos in eclampsia. So midazolam is second line. If they're still seizing despite optimally getting them, their 4 gram infusion and then 2 gram infusion and 1 gram, if they're still seizing, you want to turn to benzos as well. And it's the same dosing. So if you have an IV, give them 5 milligrams. If you don't, give them 10 IM. And you can repeat this in the same way that we've talked about before. Just to keep in mind, once they get to the hospital, blood pressure management is a big part of eclampsia management as well. So we're going to get them on labetalol, nifedipine, or hydralazine once they get here as well. And they're going to be admitted to the OB-GYN floor regardless of if they're seizing or not. So possibly the ICU if they need to be admitted, of course. Stay tuned. Ketamine is being studied pretty actively. There's some exciting data both in pediatric literature and more general literature about ketamine. I could certainly see this. I feel like Joe and some of the other EMS providers might have a little more intel on how quickly this might be implemented or what more we need to do. But I would say definitely keep this in mind that ketamine might start to be used for seizure abortion as well. There's this one trial, the KET-MID trial, where they gave a combined ketamine midazolam versus midazolam alone in 144 pediatrics. And they saw like a huge decrease in the amount of seizures. And critically, like far fewer patients had to be intubated in the ketamine group. So that's a great outcome. And then the one on the right, the Shepke trial, had 81 patients, kind of mixed. It was like adults and kids and different in like what they gave, but they also seem to suggest that ketamine has some use as both the first and second line agent. So not to dive into this too much, but I think there will be more data coming out about this and something coming down the line. That's exciting for everyone. Okay, so some other things. So like I wanted to highlight here, the most definitive management to keep someone safe from all the different complications that can happen from a seizure is to stop the seizure. So that's where you go back to if they're having a seizure, if they're in status, you want to rely on your benzos. Other things, of course, airway obstruction. People have secretions that they can't tolerate since they're unresponsive, and so they could aspirate. You have an increased O2 demand, like your brain has you have an increased metabolic rate during a seizure, and then your brain is using more O2, and so you have a chance to go hypoxic, of course. And then respiratory depression after the seizure. So when you're altered and you're postictal, you're less likely to protect your airway or breathe vigorously, and that can be compounded by the fact that you've gotten however many milligrams of benzodiazepines, which are also going to help depress your respiratory drive as well. So we have to watch their airway very closely, of course. Some things to keep in mind with airway oxygenation. So for anyone having a seizure, just to start at the kind of second bullet point area, put them on, or who's postictal, put them on a non-rebreather and maximize that at 15 liters. We want to make sure they're oxygenated. Don't always trust your pulse ox readings. Sometimes, even if they are oxygenating, that does not mean that they're ventilating. And so we have to, it's a good data point to have, but we got to continue to sort of watch for signs of deoxygenation or that they're not ventilating well. But yeah, you want to establish pulse ox, and if you can't get that, you can look for things like cyanosis or poor respiratory drive just to know if they're oxygenating well or not. Excuse me. Ventilation, so you want to rely on your capnography. This measures the amount of exhaled CO2, so your end-tidal CO2. Great marker for ventilation. If you don't see a waveform, this may suggest obstruction. So you want to watch for airway obstruction and try and clear that as best you can. If you're not seeing a waveform, it might also, of course, indicate respiratory failure, in which case they might need to be intubated and take the airway. Too obtunded in status, you want to consider giving them breaths and take the airway if needed. This is the airway algorithm, of course, from the Maine EMS guidelines as well. This is Blue 2, I believe. And we're not going to go through all this because airway is an entire talk on its own, but you can refer to this if needed. If you're in the point where someone is too obtunded, not oxygenating, not ventilating, whether in status or postictal, follow this algorithm. Some other considerations, so your electrolytes, excuse me, a little cough kicking up. Check a blood sugar, always. Anyone who's altered, anyone who's had a seizure, I'm going to check a blood sugar. Less than 60, intervene. Greater than 300, intervene. So hypoglycemia less than 60. If they are awake and talking to you and they look totally fine, you can give them oral glucose. If not, you want to establish an IV and give them IV dextrose. And if you're not able to establish an IV or don't have one quickly, then you can use IM glucagon. For hyperglycemia, I want to treat them with fluids to start to try and, they're probably profoundly dehydrated, so you want to rehydrate them, and that will help with the glucose readings alone. Low sodium. So one thing I just want to highlight here, this is something we're always going to check electrolytes on someone who's in status or has had seizures. I know that's not something that can necessarily be done within an ambulance, but we're always looking for low sodium. And so you can still give benzos to these people, even, or we can in the emergency room. So I think some people think, oh, we got to get hypertonic saline into them immediately and, correct that low sodium. But we can, if they're having a seizure, we can still give benzos as well to these people, and that will help abort the seizure. It just is not the definitive therapy in this case, since they will need to have their electrolytes corrected. We still want to rely on our midazolam, Versed. This is from the EMS protocols as well. I'm forgetting which like color and number this is, but it's the essentially the glucose to dextrose administration. So kind of goes through how much you should be giving and what you should be giving. I thought I had done a slide, I guess not, but essentially if you do 40, if they're greater than 40 kilograms, you want to give them a full dose. And so that's 25 grams of dextrose. And so you can do 50 mLs of D50, or you can do 250 mLs of D10. So that's kind of the B6B part here. If they're under 40 kilograms, then you go to 6C and kind of do a weight-based dose, and you're using D10 for that. That's mostly going to be in pediatrics with people under 40 kilograms. No IV, then you can turn to glucagon. And so for adults and most kids who are above 20 kilograms, so think like 50 pounds, you're going to give a full dose of 1 milligram IM. For kids, like babies, infants, for kids less than 50 pounds, less than 20 kilograms, you're going to give 0.5 milligrams, so the smaller dose or a half dose. Repeat their measurement every 5 minutes, watch their glucose closely, and then have them on a cardiac monitor. And again, not on my notes here at least, but if they're awake, able to swallow, you can do oral glucose as well, because they're not too altered where they can do that. So, all right, that's most of the bulk. I'm going to kind of do a case that'll walk through a few different things that we've talked about so far. So you're on duty. You get called to a 29-year-old female. She was out with a friend at a cafe, suddenly became unresponsive. She slumped over, started shaking. When you get there, she's awake. She's post-ictal, confused, tired. She is moving all four extremities. Her eyes are not deviated. They appear conjugate. They're tracking. She can open and close them to command and spontaneously. Her friend said they've not done any drugs or alcohol. She's typically clean. She seemed like her normal self in the last few days, and this morning she did not fall and hit her head. So just think for a minute, what do you want to know or do as you're just coming to the scene and getting the initial history and kind of getting her hooked up. These are her vitals. So she's a little hypertensive. They're maybe breathing a little fast, but otherwise things look pretty good. Her sugar is normal, 75. A little tachycardic, which is pretty common for people in these situations. So what are some other things you're thinking about? She starts seizing in front of you right again. So 12 minutes after the other seizure stopped, she never quite got back to her baseline. Critical action. So in no particular order, I'd say you're going to manage your ABCs. So you're going to get her on a cardiac monitor and pulse oximetry, get her on end-tidal, sort of monitor airway with oxygenation and ventilation, put her on an on-rebreather. Again, she doesn't have an IV yet. You don't have to work to establish one first. You want to do 10 milligrams of IM midazolam, and then you can work to establish an IV as well. 2.5 minute. All this was done. Good job. After 2.5 minutes, the seizure stops. She's post-ictal again. Monitoring this time, she's a little more tacky, still a little hypertensive. You got her on an on-rebreather oxygen now. Breathing a little slower. End-tidal looks fine. Average 25. Blood glucose is good. Her friend casually mentions, "I can't believe this is happening while she has a baby at home." Her friend says, "I don't think anything happened in her pregnancy, and I don't think she's ever had a seizure before." So obviously now you're in the eclampsia realm. She's 4 weeks postpartum. Remember, eclampsia can be up to 6 weeks postpartum. And so you need to turn to magnesium. Whether she's seizing or not, you need to turn to magnesium now as well. Another tip off in the case is that she was hypertensive. So blood pressure is above 1. No warrant intervention for preeclampsia and eclampsia. Critical actions, you want to get another IV in. You want to monitor. Whether seizing or not, you're going to start magnesium at 4 grams IV. And then once that's in, you're going to start an infusion of 1 gram per hour. And then you want to call ahead and let the hospital know that you have someone with an eclamptic seizure who you're starting magnesium on. She has no more seizures. we continue magnesium, we start some blood pressure control, and she gets admitted to the Lobekine floor.
Saved another one.
There we go. Yeah. So I just walked through a few steps of what we're looking for in the for a 29-year-old female patient with a seizure. I know Joe is going to be at and see if there's any questions. Obviously, we'll give you guys to type things out and let us know.
Yeah,
Okay.
no questions. No questions were left quite yet. But I have a couple that I will ask and put you guys on the spot as we give other people a chance to put some in. So this question, in theory, goes to Dr. Jones because he brought up this concept, but free play for either of you. So you mentioned PNES, so psychogenic non-epileptic seizures. I think certainly you guys gave a nod to when in doubt, just treat it. We can try and tease out on the back end in the ED after, like if this was true epileptic seizure versus a psychogenic seizure. But do you guys have any tips or tricks, things that can try and distinguish non-epileptic seizure from epileptic seizure?
Yeah, I totally agree with Joe on this, that like it's not necessarily your role in the pre-hospital setting to tease out like what's the underlying seizure disorder and if this is psychogenic or not. One of the things that I like to use, and I think we probably underutilize, is nasal pharyngeal airways, just talking about airway management. Something that's helpful if somebody's having a seizure is like, and they have some secretions in their mouth, you can place a nasal pharyngeal airway. Try not to bloody their nose, of course, because that creates a whole nother airway situation. But for folks that are having a psychogenic seizure, oftentimes that can be very stimulating and can stop the seizure episode, or they'll reach up and pull it out. That's just as a little tip. Other things that like kind of your question is more of like delineating like psychogenic versus like epileptic form of seizure, right, Joe?
Yep.
One of the things that we'll classically see, I guess, one of the worst headlocks that I've ever seen or repaired was a fella who had a seizure, rolled out of bed, and was repeatedly smashed his head against the nightstand and split his scalp like open. And so that was a very involved repair. Contrast that for psychogenic seizures, overwhelmingly, these are usually not leading to like a physical injury of some kind. It will often be while they're seated, falling onto a couch, onto pillows, that sort of thing. And then often people will return immediately back to baseline. One of the classic features of a psychogenic seizure is that there's not a post-ictal phase. And people immediately return to their consciousness. And also during that time, they may be attentive or responding to you. They may follow some commands while they're still having these kind of shaking type movements. Those are some of the things that we sort of tease out when we're asking more of these details around like the seizure. I don't know if you have any other thoughts to add.
So probably the biggest tip off is if they've had a prior history of it. Well, you guys won't necessarily know that, but we will know that once they hit the door and we can look in their chart that they've had a full workup and they've not been found to have epileptic activity. And they're meeting with a psychiatrist, they're meeting with people to try and tease out what exactly is causing these. The other is a few things. One, I think the biggest thing is if they're not post-ictal. I'd say that's like a pretty big tip if they come out of it and they're just immediately, oh, where am I? What's going on? And kind of can tell you who they are and what's happening. And then also I'd say if they're resisting manipulation, if you're trying to see if their eyes are deviated and you're trying to open their eyes and they're just holding them tightly shut, or if you're trying to, move to see if their arm will respond to something and they're holding it against you, that's something that a lot of people will do when they're having PNES as well, or some non-epileptic seizures. So this is not to say, I don't want to say that this is people always malingering and they know exactly what they're doing and they're trying to fake you or fool you. Some of these, they don't really have great control over what they're doing or how they're responding, regardless of what the cause is, but those are some fairly common tip-offs.
Yeah, I think those are spot on. Yeah, some of my key things are the no post-ictal period, no physical injuries, whether that's no tongue biting, no head injury. The forceful eye closing is a key one. Like someone who's having a true neurologic seizure, their eyes should open for you, no problem if you try and lift their lids. If they're crying or making like shrieking noises during the seizure, that's probably psychogenic. Some grunting or heavy breathing can be characteristic of either. But crying and shrieking is one that gets my attention. Side to side head movements is a little strange. Usually your head gets fixed to one side, so the back and forth head movements gets my attention. And then any kind of, it sounds a little strange, but any kind of pelvic thrusting, like a lot of this clonic movement really is the extremities and the head fixed to a side. So when someone's like lifting their hips off of the stretcher repeatedly, that is also strange and not typical of a true epileptic seizure. Um, so, these are features that I think the takeaway for me is still treat these, but you can relay, like when you guys get here, either to, the triage nurse or to the doc if you see us, like, hey, I noticed that during the seizure, this is what it looked like. And even if the triage person isn't asking you to describe it, like if you can just give a description of what you saw, it can be super helpful for us on the back end to try and tease out what may or may not have been happening. So, yeah, those are some of the key things for me there. Let's see. What else did I have? So you guys mentioned this thing called status epilepticus. Just so we can make sure we're being explicit here, what actually counts as status epilepticus?
Yeah, it's it's funny. I texted Joe and Andrew yesterday after I kind of finished putting together this talk that my first patient on shift yesterday was someone who ruled in for status who had breakthrough seizures, and he ruled in because he had four seizures in 24 hours. And between two of them that happened in the emergency room, he did not return to baseline and remained altered and postictal. And so that is one of the rule-ins, is that you have two seizures within 24 hours without a return to baseline. The other is if you have a seizure lasting more than 5 minutes that doesn't break on its own. So it's pretty. It's kind of funny you think of status as someone who's just seizing for hours and hours, but it's really not as strict criteria to be diagnosed with status epilepticus as you might expect, and probably more people rule in than we actually realize sometimes.
I think it's important in that sense because having a seizure, it predisposes you and lowers the seizure threshold. So that's why in my mind, that's why the definition is so wide like that, two seizures in a 24-hour period, because of that reason, because you're very likely to have a subsequent seizure. Often folks with epilepsy will have clustering of their seizures, where they, have some kind of trigger or event or stress or something of that nature, and then they start to have much more frequent seizure activity.
Great. And then one last piece I have, I don't know if you guys have seen these because they don't come through often for us, but vagal nerve stimulators. Have you guys come across these at all in your practice?
Only in the textbooks.
Yeah, that was in the guidelines, and I considered putting it on the slides and didn't. Maybe I should have, but I have not managed one of those before. And this is like you're way down the pathway of needing treatment for seizures, and have one of these put in. But they come with a magnet that you want to. I think it's a magnet that you hold over the stimulator, and that should activate the stimulator to help try and break a seizure.
Yeah, so this does live in the protocol. So if you ever have a patient that's going to have these, the patient or their family member is going to know and tell you about it. And if someone like this is in your community, you'll probably know. But basically, the whole idea of a vagal nerve stimulator, or sometimes you'll just hear it called VNS, it's kind of like a internal defibrillator for the brain. And so, yeah, it lives usually in the upper left chest, similar to where you'd see a pacemaker. And it's exactly right. There's a little magnet that you wave over this thing, and it takes advantage of the vagal nerve, which is, you can think of someone who's like vasovagal syncope. You get high vagal tone, and it basically is a giant reset because the vagus nerve suppresses just about everything else in the body. So the goal is to use this device that's implanted in them to have a bunch of vagal stimulation to try and break and suppress this refractory seizure. And it is a magnet that gets waved over it to make it work. So if you have folks in your community who have these, you'll probably know about it. Be familiar with them. It is in your scope of practice to help use their magnet to do this with their device. So I in 4 years in Portland, I've seen one patient come through with this. So it is not something you commonly see, but it's definitely something worth being aware of.
Joe, do you know if the regular old circular magnets that we use for ICDs and pacemakers, if that works for those?
I'm told that magnet would also work on a VNS, but I've never used it myself for that purpose.
Curious.
All right. There are no questions that have come in yet, despite me rambling, but any other clarifications people have, things you want to know about seizures, seizure care? There's lots of words and terminology get thrown out in seizures. If you want to know what something means, um, feel free to drop it, either the chat or the Q&A, but otherwise, thanks to Dr. Jones, Dr. Connolly for taking the time to give this chat. It's always nice to sometimes hit on both the more kind of niche, hot topic-y things, but also some of these bread and butter topics like seizure that we see on a daily basis. All right, we got, let's see, one Q&A here. Can any license level use the magnet or just medic level? So I'm pulling back up the protocol right now as I answer this for you, but it technically lives
I got you, Joe.
it's one of the little golden colored pearls at the bottom of the protocol. And all it says is people who are having seizure activity consider activation of it. And I don't think I mean, it lives underneath the paramedic on the left there. That said, if you are out in a remote community and you're at the EMT level and someone has a VNS and you otherwise don't have access to these anti-epileptic drugs, I would be making a phone call to medical control early and say, hey, I have a patient who's seizing. I'm an EMT. They have this device and they very well might be able to talk you through using it and doing that appropriately. So the way the protocol is structured here, to me, this technically lives under paramedic. That said, I recognize, having myself been an EMT in a rural setting where when I otherwise don't have anything else to do, I think it's a great time to use medical consultation in a phone call here. All right. That was the one question I saw in the Q&A section. And then looking through the chat, a bunch of thank yous coming in, compliments for you guys, but I don't see any other further questions. So I think on that note, we can give folks 5 minutes of their day back. As always, fill out the eval that gets dropped both in the chat here or should get emailed to you as well. Let us know about future topics you may want. We have another trauma lecture tomorrow, same time, 2 o'clock. And then next month, we have one of our pharmacists coming for the medical topic. So plenty of webinars coming. But yeah, as always, let us know what you want to hear about in the future, and we'll keep all of these going. Thanks, folks.
All right, thanks everyone. We'll see you in critical care soon.
See ya.